for the invitation. It's a pleasure to be here. Um, you know, how do you take a physician out of their comfort zone, bring them to an AI conference, I think is, I think to answer maybe a little bit your question is, I think we through my collaborations and working with you all, which has been really a tremendous experience, it just has shown how we are in two different worlds, and the physicians are, really focused on the individual, the patient. I think you all are looking at the big data, and here we have to somehow merge and meet in the middle, and really how do we bring this technology, which I think is really something that is coming, and that we all as physicians are going to, whether we're ready or not, we're going to have to learn to embrace it, and how can we bring it into our practice. So I'm going to talk a little bit about, spend a little time just on what kind of data that we collect, so you can understand how I as a physician may be looking at the data, and then I'm going to put in some highlights, I hope, that can show you what I'm thinking as in terms of bringing in AI to that perspective. One thing is, even before patients come to see us in the sleep lab, patients are seeing regularly their primary care physicians. And here there's tremendous data that's collected. And I think that there's an opportunity, actually, that AI is involved before they even come see us, right? So that we can identify patients who are at risk, who are otherwise being missed. Just to give an example, obstructive sleep apnea, which you've heard a little bit about today, is very common. It depends on different ethnic groups. African Americans, for example, 24% of all adult males have an apnea-hypopnea index of 15 or higher. That's how many breathing stoppages per hour of sleep. That's a moderate sleep apnea. 95% are undiagnosed and untreated. And there's the data that the primary care docs collect, age, weight, et cetera. These are all factors that we know, higher weight and so forth, or age, that are risk factors for sleep apnea. They can even express symptoms of sleepiness with their primary care doc that is already in their own electronic medical record system, right? And then there are patients that undergo different procedures such as 24-hour Holter monitoring, and we now know through some nice data that's being shown that you can take the 24-hour Holter monitor, this is EKG data, and identify signs of sleep apnea just from these data, right? And so I think that this idea of AI only for the specialists, I think everyone's going to be using it. How do we identify patients at risk who are in the general population coming to the primary care offices, and identifying those most at risk and most likely could benefit from further evaluation with a specialist. Sleep medicine, we are rich in data. Let me tell you, there is so much data in our field, and it starts with just the same kind of demographic data, age and sex, symptoms that the patients have. And I think there are, as you saw, there are some clustering that you can base just on symptoms, clustering based on symptoms plus physiological data and so forth. Past medical history, high blood pressure, diabetes. These are sleep apnea, for example, is probably one of the biggest risk factors in contributing to diabetes and hypertension. Different surgeries they've had can impact on sleep and sleep disorders. Medications, sedating medications, and so forth. Family history and many, many types of data. In terms of the physiological data that we look at, this can be already from laboratory blood work. There are known biomarkers. We talked about narcolepsy type 1. HLA typing, this is a type of, can tell us this is the patient's at risk of narcolepsy. We get cerebral spinal fluid. Narcolepsy is caused actually by the loss of hypocretin neurons in the brain. There's an area in the hypothalamus, a neuropeptide called hypocretin. It is lost, probably immunologically driven. And we can see that they don't have hypocretin in their CSF. Actigraphies is we measure activity over several weeks in duration, that we can get an idea about their sleep-wake rhythm. The polysomnogram that we talked about earlier, you've heard already about, that we have many variables. I mean, 50 variables is really a minimum. Sleep efficiency that we can determine, the sleep latency, the different staging that were mentioned earlier, the stage 1%, or non-REM sleep has 3 different levels, et cetera. And I'm going to talk a little bit about the other ones as we move forward. But one thing I think is also important is that we should understand the structure of sleep. How is sleep normally structured? You've seen some of this from other slides before, what we call the hypnogram. And what you can see is when you go from wake, you go into first non-REM sleep in these 3 different stages: light non-REM sleep, stage N1, down to deep sleep. And then about every 90 minutes, there is a REM, a rapid eye movement REM sleep that occurs. And this structure, as you can see, is something that we should all see from everybody and when we measure them. And it's how the sleep progresses throughout the night that carries tremendous information. So it's not just, can we score the N1% or N2%, and I get a little readout that tells me whether or not you're getting the normal amount of slow wave sleep. I want to know also as a clinician, what does the structure look like? Is it disturbed? And I'll show you some examples of why that may be important. Regarding actigraphy, this is just that accelerometers that people can wear. And it's been done for many years. Patients wear these actigraphy devices for several weeks. And the display of these actigraphy is very important. You can see we've taken 14 consecutive days in these 2 examples, and it's displayed from noon to noon. And when you see the dark bars, that's the high activity counts, and at night from midnight to noon, you see this very, very minimal activity. So here we can see a lot of information. We can see about how much time the individual is in bed on a night-to-night basis. We can also get information about how consistent the bedtimes are or the wake times are. This patient, example 1, is going to bed anywhere from somewhere around 11 o'clock at night to almost 6 o'clock in the morning. So there's tremendous variability there to their bedtime, and also the wake time, sometimes getting up here almost at 2 o'clock or so in the afternoon. So this kind of information tells us there's something going on with their sleep hygiene, as we call it, could be contributing to their symptoms of sleepiness. On the other hand, the other patient has almost no good rhythm that we can almost identify or really identify. And so this carries tremendous information. This is a 30-second epic of sleep, of a polysomnogram and a recording. And your top 2 channels are the eye movements, and when there are none, we just pick up brainwave activity. The chin muscle activity, 3 channels for the EEG, the EKG, the leg movements, snore microphone, oxygen saturation, and there's 3 channels for breathing. And what you can see from a sleep apnea is you have this and the nasal airflow is pretty flat, but the chest belt and the abdomen belt are demonstrating an effort to breathe, so they can't get air. And at the end of the apnea, there is an arousal to reestablish the airway and the muscle tone. And in the meantime, you've had a drop in oxygen saturation. And when you look at these data over the entire night, you can see at the top the hypnogram where this patient is spending most of the time only in this very light stage 1 sleep. Because there's so many breathing stoppages, the respiratory events are little bars, and this patient had 84 breathing stoppages per hour of sleep, and the oxygen saturations are dropping regularly into the 70s. So this is tremendously fragmenting the sleep. The patient is unable to maintain sleep, and you can just, I think, gather from the data, looking at what kind of data we get, it really can provide tremendous information. Here's the same patient on the CPAP device. This is a mask that goes over the nose, just blows a little bit of air into the airway and helps maintain the airway open. So now the patient can breathe in and out without difficulty. Almost the breathing stoppages have stopped. And you can see now that normal structure is there again, right? They have cycles they have 4 REM periods. They're now maintaining sleep, getting some deep slow wave sleep that they didn't get before. And how this structure over that 8 hours is very informative. Now, one of the things that we deal with patients, and I think from an AI perspective, how could it maybe help us as clinicians? You know, this CPAP device down here, this is the pressure that goes through the device, and it's from 5 centimeters of water pressure up to about 10 or 11 centimeters of water. This pressure that the patient receives through the mask is actually super important. If it's too low, the breathing stoppages persist, and if it's too high, they're not going to tolerate the pressure. And there's been some work trying to extract the data from a machine learning perspective from the actual data to give us an idea as to what the work of breathing, the respiratory effort, is required in this patient. Because the higher the respiratory effort, the more likely the higher pressure they're going to need to keep the airway open. And this is a study that was done looking at this, trying to estimate this. And one way to measure the gold standard for respiratory effort is that the patient, through the nose, swallows in the esophagus a pressure transducer. And so when you take a breath in, it creates a negative interthoracic pressure, and that can be measured. And these patients with sleep apnea generate huge negative pressures because the airway is closed, and they're trying to get air through, and these pressures become very deep. And so they actually, at Stanford, they used to do this systematically on every patient that came in the sleep lab. And so they actually used a machine learning approach and modeled it with directly combining with the esophageal pressure monitoring of over 1,000 individuals. And they could actually get and extract from the data what their work of breathing and the pressure, to know the esophageal pressure just from the actual data that was acquired. Now, this could be potentially helpful to help us as clinicians get already a starting pressure so we can know where to start the patient when they are on CPAP, for example. Multiple sleep latency tests, we'd use this to measure how much objective sleepiness the patient has. We put the patients down for 4 or 5 naps during the day every 2 hours. And here we're measuring how long does it take you to fall asleep. Well, control people, without any problems, most of us in this room, I hope, will take about 12 to 15 minutes to fall asleep. So even we will fall asleep in this multiple sleep latency test. Narcolepsy patients, however, typically fall asleep 5 minutes or less. So we can really get an objective measure of sleepiness. Now, just from the hypnogram, again, looking at the narcolepsy patient, this loss of neurons in the hypothalamus has a consequence of not just causing sleepiness, but it disturbs the normal structure of sleep. And you can see this very fragmented sleep, and you can see here also from wake, they go almost immediately into REM sleep. And so that's a typical finding in narcolepsy, is that instead of the latency being about 90 minutes, they go very quickly into REM, very different from this idiopathic hypersomnia that you heard about, which has a normal structure, but they just sleep a lot. And you can see the REM latency is normal. Now, hypnograms have been the way we traditionally have looked at, for example, the structure. And it relies on with the scoring that is an all or none, right? Is it stage N1, stage N2? And you heard from Luigi that sometimes we as clinicians can't agree as to what is the actual stage. And I think that this is an important point to remember. And it's important because, especially in neurodegenerative processes, a state like narcolepsy, these individual epochs can be very difficult to differentiate, and that's because patients tend to have a loss of boundary state between the different stages. And it's just to give an example, this is from Stephenson, was published in Mignot's group in Stanford. They look at a probability of the state at any given time during this 8 hours of recording. And you can see in the non-narcoleptic subject, white is awake, red is this light sleep, and there's a probability of each of those states. But you can see it's usually a probability that's between one or another state. But in narcolepsy, you can see, for example, between 3 and 4 hours into the recording, they have features that can resemble up to 4 different states. It's not so clear. Is it stage 1? Is it wake? Is it REM? And I think this kind of information gives us another granularity of what we're looking at, and I think helps the clinician because we can see, okay, maybe there are some, this is not such a clear state, for example. So what are the goals of AI from a clinician's perspective? One, I think, is to facilitate and accelerate workflows. The scoring of those polysomnograms is very labor intensive. It takes a tremendous amount of time. And I think by having a system that can automatically score, it would give us, I think, some help. Also, stratifying treatment approaches. I mentioned just the amount of pressure that we should prescribe with the CPAP device. It would be nice to have some kind of system that can already give us that information. And I think it should be, to allow physicians to, it's important to compare the AI results with the raw data that we see that come out from that we can see from the recording, so we can really have a confidence level or not from the recording. And AI should ideally provide new information that is not previously available from traditional approaches, like the hypnodensity graph. I mean, that gives us not just a hypnogram, but also, what is something about the likelihood that the states are maybe not so clear. I would love to have as a way to determine what the individual's intrinsic sleep need is. People, don't realize some people only need 4 or 5 hours of sleep per day, and others need 11 or 12. And for us as clinicians to determine if you're sleepy, because you're sleeping 9 hours, but normally you need 11, it's very difficult for us to know that. And I think that there's some of these devices and long-term monitoring that may provide us more information. Oriella is going to present later about the wearable, so I'm not going to say much about that. This is using a Fitbit device. But I will say, if you look at Fitbit, for example, and a patient will come to you and show them on the cell phone, here's my sleep. And they show like 4 days in a row. The problem is it's always displayed from the start of sleep. I don't know if the start of one sleep was at 4 in the morning and the start of the other was at 11 at night. When you display it for the physician, again, from noon to noon, I can see now how not only the structure of sleep, but how it's changing from the timing of sleep. So here's more information. And I think that the displaying of information for physicians is very important. I'll save this for you later on. All right. So limitations, my last slide, limitations that I see of AI from a clinician's perspective. Number one, I think, is lack of explainability. I mean, a lot of times AI will spit out some kind of information for us, and it's like a black box, and you have to understand, as physicians, we are a skeptical bunch, all right? We have to have confidence that what we're looking at makes sense, and we like to have an ability to actually verify that this makes, where and why are these the data coming the way they are. I think it's important that there is the AI has approaches that require a close collaboration with the clinician, so we can get feedback that provides refinement and that builds confidence. Right? This is really essential to really integrate AI into a physician practice. And what do we do if AI gives a different answer than what maybe I, as a clinician, expected? Will physicians start to question themselves? Maybe I'm not thinking about this properly. Will a generation of physicians become overly trusting to AI? And will there be a decrease in self-reliance? I used the example of there's some studies that were done of taxi drivers in London, and before GPS, and the size of their hippocampus is huge. Why? Because there are place cells in the hippocampus, and they can really navigate on their own. Introduction of GPS, hippocampus now is much smaller. I mean, our brains are actually adapting to whether we can be self-reliant or not. I have no idea if AI is going to have an effect on our own self-reliance. I think another point that's important is training sets versus real patients or subgroups of patients. If you take healthy controls and that's your training set, and now, which is a nice consolidated sleep pattern, as you saw earlier, and then you throw in a sleep apnea patient with severe fragmentation of sleep, guess what? I'll be surprised if your algorithm is going to do nearly as well in really scoring that kind of a training set. So we have to be really cautious in neurodegenerative diseases. I mean, I can tell you, somebody who's a degeneration, even I can look at the scoring, and I can't tell. Is it awake? Is it sleep? It can be very, very difficult. So you have to be careful of what your patient groups are compared to the training sets. And will AI stimulate or stifle new discoveries? On some hand, maybe it may create some new discoveries. On the other hand, if we just become blinded and overly reliant, we may ourselves stop asking questions. And it's by us asking questions that generate new ideas and generate hypotheses and hypothesis testing. And finally, and I think, Flo, you mentioned this earlier, there are many comorbid sleep disorders, right? So patients have sleep apnea and narcolepsy. And how well can an AI system really identify these comorbid conditions? very challenging. All right, so I leave you with that, and I'd like to thank my team and the collaborations that we've had with all of you. So thank you very much.